Rhinologic Society and Merck for sponsoring the symposium. Why are we here as otolaryngologists? And I would say that the majority of our patients with chronic cough are presenting with real or perceived postnasal drainage, and they have this globus or throat clearing type behavior. I believe everyone can see my screen. I'm at Geisinger, Central Pennsylvania. It's a large rural healthcare system that really reflects the bread and butter about what we do as specialists in the broader community. These are my disclosures, activities related to education and understanding the need for chronic cough initiatives such as this. I also serve on the Chest Cough Guidelines Committee. There's no time in recent history as important as today with regard to coughing. And from a public health relevance, you can see this Schlerian light beam refraction study where you can actually see the cough goes well beyond the periphery of a person, really as much as 2 meters beyond the cough without covering one's mouth. So you can understand the particulates and that can be transmitted to the general air. This is actually understood well over 100 years ago. In New York, there was a tuberculosis pandemic or epidemic where they recognized that the public health relevance of coughing and spitting was transmitting the disease. So they put people in sanitariums, and they also had the first anti-spitting law going back to 1895. Us as physicians think of really almost in a comical way the idea that physicians used to advertise cigarette smoking. But here, this example from this one brand recognized that smoking and cough go hand in hand, this one brand supposedly being healthier for you with a reduced cough. And that really does pay tribute to the idea that coughing is a major contributor to, or smoking is a major contribution to cough. But if you're coughing in this age of COVID, everyone will be looking at you. And so the relevance and quality of life, the social interaction of patients with longstanding chronic cough is that much more affected. This is the global distribution of COVID. And as you know, that we're entering this essentially a third wave globally. But the thing is that COVID has a lot of relevance, not just to public health, but also to chronic cough, because it's an example of the kind of things that we think about. So what are we thinking about with cough? We're thinking about a protective mechanism. And how did we evolve this protective mechanism? It goes back 300 million years ago. This is a photo from Apollo 17. And 300 million years ago was our very first recognition of the larynx in evolution. It was the African lungfish who spent about 97% of its time swimming in lakes, breathing through its gills. And then for 3% or so of the time when lake beds would run dry, it evolved the ability to breathe through a primitive larynx. So how did this African lungfish develop its ability to protect itself for the 97% of time it was underwater? Well, it developed very tight laryngeal and pharyngeal constrictors and neural feedback mechanisms that resulted in adductory behavior and protection, shutting down that larynx, which is essentially a protective or cough-like mechanism. So I like to think of the aerodigestive tract as a physiologic unit. The upper gastrointestinal system, the respiratory system, all merge at the level of the larynx. As a laryngologist, but also a rhinologist, I still think of the larynx as really the center of the universe when it comes to the cough. And then, of course, we have the musculoskeletal system, neural feedback regulation, and then mucus, or the endocrine exocrine systems, heightening the triggers to the cough. And the larynx is really centrally located in this physiologic unit. It's very sensitive to perturbations. And from an evolutionary standpoint, protection is its primary role, at least for the 97% of the time that the lungfish was underwater. Of course, respiration and phonation. And when we think about aspiration protection, we also have to include cough, because a competent cough is critical to overcoming the consequences of aspiration. just think of your vocal paralysis patients with a linear cough instead of a more competent cough that has expulsive or accelerative forces. So I wanted to show you a quick example of what the cough is. And all of this happens really within 2 seconds. A deep inspiration, glottal closure, diaphragm relaxation, thorax contraction, tracheal narrowing, glottal opening, and expulsion. So here I am doing a stroboscopy. I have a Hopkins rod telescope in the back of the mouth of a patient. She's not a cough patient, but at one point, the tip of my scope touches the back of her pharynx. It's not even touching the larynx, it's touching the pharynx, which triggers that afferent feedback loop that results in the triggers mechanically stimulating the cough. So everyone see how fast that happened? So it's really phenomenal how integrative the cough is, not just from a physiologic standpoint, but from a sensory standpoint, being aware of sort of the global sensorium. So this is a National Ambulatory Medical Care Survey showing the impact of chronic cough in medical practice. And in the US in 2010, 3% of all physician visits were for cough. Now, just to put that in the context of us otolaryngologists, how many visits did we see for all reasons that same year? We only saw 20 million visits for all otolaryngologists in the US that same year. So 31 million visits for cough and only 20 million visits to otolaryngologists, including cerumen and sinusitis. You know, this really pays tribute to the idea that that we as otolaryngologists are wholly underserving the chronic cough patients. And I do want to take you on a tour of the most common etiologies of cough and why it is that otolaryngologists play a special role. And I think it's obvious to every one of you that we have the fiber optic or the flexible nasopharyngeal laryngoscopy exam that's not generally afforded to other specialties. So we can have a physical exam not just on the outside of the body, but we do office-based endoscopy to understand which are the main contributions to the cough. So here's a patient who came to see me with a globus sensation, non-productive throat clearing, and voice pitch limitation. He's an actor, and there's a seasonal variation. You'll notice these cobblestones in the back of his pharynx. That's an early cue, mucus stagnation. And then during the stroboscopy with a flexible scope, you can actually see that mucus that's aggregating on the vocal folds. You actually saw his cough just a few seconds ago as a result of that mucus aggregating on his vocal folds. So this patient obviously has some degree of chronic rhinitis. I'm going to start with this figure here. Let's place chronic cough in the center of the universe. That's the larynx, of course, coming from a laryngologist. And here's the nose, that's just above the throat, and the rhinologic contributions that can result in real or perceived postnasal drainage include allergic rhinitis, sinusitis, and then non-allergic rhinitis. This is a typical example of that string sign that Jackie Corey from Chicago had mentioned. She's an otolaryngology allergist, as typical of laryngitis related to allergy. Here's an example of a 78-year-old physician. He had an upper respiratory infection 2 months earlier, and this is his nasopharynx. This is eustachian tube orifice. A little bit of stagnant mucus, but it's not really clear. It's a sinus infection. And he has a cough with shortness of breath. His cough is non-productive. So this is a beautiful example of how a non-productive cough is not necessarily diagnostic of nothing that's going on from a pulmonary standpoint, and how our exams, looking at the larynx, can actually see stagnant mucus from really a subacute bronchitis in this case, or an evolving pneumonia, that the patient is not aware of. He does have the shortness of breath, dyspnea on exertion, but his cough is non-productive. And typically we think of bronchitis as having a productive cough. And my best assessment is that his lungs were not strong enough to actually produce anything, and he would swallow, or this mucus would just stagnate. So how are we going to add the lung disease to this little picture? Well, he probably started off with a sinus infection that just dropped into his chest. So here we are with the lungs just below the larynx. And we're all aware of cough variant asthma. Here's his pulmonary infection, and there's a host of infections. And there's also a number of other inflammatory diseases in the lungs, like non-allergic eosinophilic bronchitis. And each of these three things, just like in the sinuses, allergic rhinitis portends sinusitis. And these factors all have a synergy. So just to make sense of this figure, rhinologic diseases could stimulate the cough directly. Pulmonary diseases can stimulate the cough directly. But can rhinologic disease stimulate pulmonary disease, which in turns triggers a cough? And I think you're all familiar with this term unified airway. If you have allergies, you're prone to sinusitis. If you have allergy, your asthma will be worse. If you have sinusitis and asthma, you're one step away from asthmatic bronchitis. And then, of course, there are neurologic reflexes that tie the upper and the lower airway together, and of course, mucus trafficking. We have common muscle groups that are involved between the upper and lower respiratory group. Respiration, swallowing, cough, and vomiting, or emesis, also have very overlapping 10th nerve nuclei that have a lot of crosstalk. So there's neurologic reflexes that bridge the gap between the upper and lower airway also. This is just a simple slide to look at differences between classical asthma, cough variant asthma, and eosinophilic bronchitis. And I do want to draw this distinction because both of these, asthma and eosinophilic bronchitis, are treated with inhaled corticosteroids. The difference is that you do not have peripheral bronchoconstriction with eosinophilic bronchitis. The difference here is that a mast cell is within the airway smooth muscles for asthma and cough variant asthma, but not with eosinophilic bronchitis. This actually needs to be diagnosed with bronchoscopy and cell washings. So here's a pictogram showing the mast cells in the smooth muscle for asthma and not in the smooth muscles for non-asthmatic eosinophilic bronchitis, both of which trigger cough. And I did want to just briefly touch on the crosstalk between inflammatory and infectious diseases in the lung, that it doesn't just stop at bronchitis. There's also bronchiectasis and bronchiolitis. You're welcome to circle back to these slides to focus on the details and radiographic findings. Incidentally, we as otolaryngologists should have mastery of the lung diseases so that we can better partner with our pulmonologists when we share cough patients. I did want to circle back to COVID. Early in the days of COVID, we did not typically do tracheotomy at 4 to 7 days for a ventilated patient. And the reason is that based on SARS-CoV-1 data, patients were not expected to survive past 3 weeks. And there was a 50% mortality rate once they would be on the ventilator. So the risk of exposing the healthcare team to active COVID during the first 2 weeks of the infection, or the risk of opening up the airway with a tracheotomy to expose the entire hospital and surrounding patients to active COVID was not justified by early tracheotomy based on a number of consensus statements. What about subglottic stenosis as another pulmonary etiology from a ventilated patient? So the answer is yes, absolutely. You can also see glottal stenosis. So when a patient's been intubated, we have to keep in mind that the longer the intubation, the greater likelihood of posterior glottal stenosis. So these are just 3 recent patients that we had seen in my practice. This patient came into my clinic without a tracheotomy, chronically dyspneic after a 3-week intubation for COVID. And you can see this dense posterior glottal stenosis on this staging exam. in the operating room, and obviously this was addressed, and the patient underwent tracheotomy during the time that we would address this. Here's a patient that had already had a tracheotomy, and there's dense granulation tissue with a posterior glottal stenosis. And this patient here with a tracheotomy has a dense posterior glottal stenosis that was divided, and I was able to get my Hopkins rod telescope through the vocal folds only to find that there was a suprastomal hood with stenosis above the tracheotomy tube. So multi-level stenoses here, glottic and subglottic or suprastomal, are also present in chronically intubated patients. Here's an example of a patient that was sent to me with chronic cough. There's no video here, but the cough was worse after eating. Patient had a history of asthma, and there were nocturnal arousals. The patient was actually sent to me because of concern for sleep apnea, because the arousals would wake up with gasping. And here you could see interarytenoid edema. You lose definition of the arytenoid cartilages, effacement of the ventricles, swelling of the vocal folds consistent with pseudosulcus is the term we call it, and also demarcation of the coloration in the larynx, discolored mucus. We suspect this is a refluxing patient. You can't do a pH probe or impedance probe on a chronic cough patient. They really will not tolerate the probe very well. I like the Bravo capsule, but off reflux medicine to determine how severe the reflux is. And I always look at the tracing. If you were to look at this tracing at pH 4 and pH 5, sometimes you see different cutoffs. But this patient, when upright, when lying down, has 22% of the time refluxing. So is this likely contributing to the cough in that patient or the waking up gasping? Well, I think yes, because when they're lying down, 20% of the time they're refluxing, so it's likely associated with those gasping episodes. This is actually an old slide from a number of series going back to the 1990s, but few of these patients really have heartburn or dyspepsia. Most have hoarseness, cough, and globus. So here I am throwing in our pictogram reflux. Now, why is this a two-headed arrow? And it's because when you cough, remember there's that diaphragmatic relaxation. The lower esophageal sphincter is at the level of the diaphragm. So the act of coughing will actually bring up regurgitation or reflux. Now, if you're refluxing and have silent aspiration, perhaps while you're sleeping, that silent aspiration can cause a pneumonitis that can then trigger cough. So it gets fairly complicated. And if you're regurgitating and aspirating directly, you'll sense that in the level of the larynx from mechanical stimulation. And your C fiber receptors are acid sensitive as well. Plenty of studies going back to the 1990s, and this slide is really 20 years old, and it's no different than it is today, with plenty more studies that show that reflux and asthma do go hand in hand, especially tied to the body mass index. And here I wanted to summarize potential or real mechanisms for reflux and cough. And I did want to emphasize this vagal mediated reflex. That was the example I showed you earlier with a patient. She had stimulation in the back of her pharynx, and that triggered the cough. Oral otolaryngologists, you put the scope in the nose when they're not anesthetized, and they'll cough before that scope even gets to the nasopharynx. And similarly, you can have distal esophageal reflux before it comes up to the larynx to trigger the cough. Again, this goes back 300 million years to the earliest protective mechanisms and neurologic reflexes to shut down that larynx. I don't want to belabor all of the different mechanisms of cough that really create an overlapping diagnosis. This is the one that we see, globus with throat clearing. And it can overlap with paradoxical vocal fold motion, the irritable larynx, neurogenic cough, viral syndromes with vocal paresis or hyposthesia, vocal paralysis, aspiration, occupational and environmental, which dovetails in a holistic way with rhinologic disease. And then these new terms, psychogenic cough is now somatic cough syndrome, and habit is now considered a tick cough. So here we are adding the neurologic etiologies, including tumor and systemic disease, which includes cardiac disease such as high blood pressure, taking ACE inhibitors, as well as the autoimmune disease such as granulomatosis with polyangiitis. So if we were to look at the most common causes based on the American College of Chest Physician evidence-based clinical practice guidelines going back to 1999 is tobacco, postnasal drainage from the nose, reflux, bronchitis, asthma or reactive airway disease, and ACE inhibitors. And then there are the less common things. Let's not forget carcinoma. And 2/3 are multifactorial. You know, the interesting thing about this slide is that what it leaves out, and this again goes back to 1999, it leaves out Professor Sadia's fantastic conclusions that chronic cough is not just a symptom. It is a disease when we think about hyperresponsiveness, phenotypic switching, central sensitization, and impaired suppression. So these are real disease features. This is not just a number of physiologic contributions to a cough. And usually the chronicity dovetails into the phenotypic switching and the hyperresponsiveness examples. So chronic cough. What is refractory chronic cough? What's unexplained chronic cough? And basically the distinction here is that refractory chronic cough is that we understand the triggers, the physiologic things that are contributing to the cough. We've optimized it, but the patient is still coughing. Unexplained chronic cough is when we've done objective evaluations for any number of suspected contributions, and we still cannot explain the cough. In either case, these are the same patients that we've been talking about that have significant impairment in quality of life, and now they're increasingly socially isolated because of the pandemic and other infectious disease concerns. You know, when we think of how to treat this, and we think of where our patients fall into the spectrum of real and the new disease state of chronic cough, we think of, is there a stimulus, and is the cough under conscious control? And this is really where the speech and language pathologist can come in doing what's called laryngeal desensitization therapy or respiratory retraining, which goes beyond the scope of this talk. But I did want to get to the guidelines. CHEST came up with guidelines in 1998, 2006, and now we have living guidelines with worldwide interprofessional experts. I'm one of these 55 or now more panelists from 21 different disciplines, including patient advocates, and in the process of cycling through 42 important topics that will cycle through again as new research becomes to the forefront. And this is a complicated figure or flow diagram, but the big thing is think about smoking and occupational exposures, ACE inhibitors, which should be stopped at the first presentation of a chronic cough patient unless there's overwhelming evidence that it's a different etiology. And then, of course, the importance of understanding the potential for lung disease. So chest radiography is also best practice. The European Respiratory Society came up with guidelines going back about 2 years now. And these were a phenomenal addition to the chest guidelines. And what the European guidelines added to the breadth of the chest guidelines outside of a slightly different paradigm is the importance of understanding the severity of the cough, outcomes measures. Here, the example is a visual analog scale, but there are other scales that measure the severity of cough that include Leicester cough index. So objective measurements is really emphasized in the ERS guidelines, as well as the severity of illness, such as the quality of life indicators or the outcome scores, such as the visual analog scale. The other big contribution from the ERS guidelines is the distinction that pediatric and adult cough are really different presentations, and they have different etiologies, so we should think of them with a different presentation. And here, without going into too many details, it really divides the cough for pediatric into a dry cough or a wet cough. This is a nice condensation that I put together on how to think of chronic cough in the generalized patient. At 8 weeks on first presentation, really strongly considering eliminating the ACE inhibitor and chest radiography. But very often with a good otolaryngology exam, we may get a good sense of which of these main contributions are associated with the cough, in addition to the neurologic. And here, this is that role of respiratory retraining or laryngeal desensitization. And it's really otolaryngologists that are first to think of the partnership with speech and language pathologists. But I'll tell you, in my practice, I do not like to go much past 6 weeks regardless. Or if the patient's had the cough for years, I jump right ahead to objective testing. And so you really need to quantify the contributions for those things that are likely contributing. Here's just a reference on that flow diagram in case anyone wants to download it. And in that same publication, we have an example of all of the different procedure-based diagnostic tools that we have available to us that has strong relevance to otolaryngology practice. I did want to conclude with some thoughts on how to manage refractory and unexplained chronic cough from a pharmacologic standpoint. So the role of cough suppressive therapy is to improve the quality of life in these patients. And there's evidence to support that speech therapy guidance on switching from the cough reflex toward dry swallow, or an awareness or an avoidance of the environment that triggers the cough. But what is pharmacotherapy? So yesterday, today, and tomorrow. Yesterday, this is about 140 years going back. Cough, this elixir was glycoheroin. Looks like these pictures that I found off the internet were from before and after. I wouldn't recommend that for today's pharmacologic suppression. Here's another example going back about 140 years. I don't know if you can read this very well. Alcohol, cannabis, chloroform, and morphine sulfate. And it's advertised as a one-night cough syrup. And that's probably because if you survive the first night, you've made some progress. Most people probably in today's day and age would not survive that first night of this combination. But there are guidelines relative to this unexplained chronic cough, and that adds to the speech therapy and pharmacologic suppression. And the interesting thing is, of all these different suppressants found in the literature, really we have best practice evidence, high-level evidence for codeine, morphine, and gabapentin. And even though we have a fair amount of anecdotal evidence, we do not have high levels of evidence. Dextromethorphan is one other that has low levels of evidence in America. That's an over-the-counter medication. But I did want to finish with the newer classes, the future, which is today, of purine receptor blockers, these P2X3 receptor blockers that are more prominent in the chronic cough patients and the nerve increased sensitization syndromes. And this has a number of different sites where this can serve as a suppressant for the hyperexcitability of the cough without taking away other normal stimuli for the cough. So in theory, this category of medication may desensitize the hypersensitive reflexes without taking away the ability for one to cough for the protective mechanisms. Gefapixant is the medication by Merck in a phase 3 clinical trial. So I believe it's not fully indicated at this point. And then there are others from other companies as well under investigation. So there are great things on the horizon for potential treatment of this cough hypersensitivity. I do want to conclude with my thoughts that it's really important for us as otolaryngologists to find good partners in gastroenterology, pulmonology, allergy, in order to understand and quantify the contributions to cough from all of the different known etiologies. Don't forget that speech and language pathology and pharmacologic suppression may play important roles in the quality of life and management of cough patients. But I do want to leave you with the idea that there's a systematic protocolized approach delivered through best practice. The CHEST guidelines and the European Respiratory Society guidelines that may help us understand and manage our patients better. Thank you.
Okay, thank you to all of you for these very nice presentations. We have few minutes, not much, to make some questions. I will appreciate that you give very short answers, a little bit longer than yes or no, but short answers. The first question will be for Professor Satya. You have shown a couple of slides, one showing that the chronic cough is very prevalent or more prevalent in women than in men. But in your study, this doesn't occur among smokers. Among smokers, it looks like even the women are lower than the men. How you can explain you that it's some effect related to hormones or whatever?
So there's two things, it's a very important distinction, is that when you look at the data in the general population, in everybody, for example, in the Canadian study, we looked at 30,000 subjects across the whole of Canada who were just from the general population. In that population, the male to female is actually more common in males, cough. The 2-to-1 ratio in females is only in the specialist clinics that we see. So that's the first point to make, is that in the general population versus the clinic, there's a long pathway to get from the population to the clinic.
I see.
So that's one important distinction. And the second thing is that, yes, the truth is that nobody really understands why this is more common in females in clinic. Lots of things have been postulated with hormones, comorbidities, but I haven't seen any evidence which is conclusive to suggest why this is more a problem in females, even after adjusting for smoking.
Thank you. The following question will be addressed to Professor Altman. In the first presentation, it has been shown that capsaicin is very much used for stimulation, for triggering, for sensitization. I would like to know if it has been tried to do, like, for example, in idiopathic rhinitis or non-allergic rhinitis, to do some kind of capsaicin desensitization with success, or this is too dangerous to be done in the larynx?
It's a great question, because I have pulmonologists that tell me it's dangerous to do a methacholine challenge on some of their patients because that could really trigger respiratory compromise. And I agree. Some of the most fascinating patients in my career came from the World Trade Center terrorist attacks in New York. I was working in New York for 10 years. I took care of these first responders and others that had been exposed to this massive plume of alkaline dust that they filtered out in their nose, small particles of polyaromatic hydrocarbons that came into their chest, and they were chronic cough patients. And we actually published on a speech pathology or speech therapy approach at laryngeal desensitization for these patients, and how to slowly reintroduce things that they were hyper-responsive to. So I think that there is a really strong analogy about, that's a great idea, using capsaicin to challenge patients that are in the midst of their rehabilitation. In the similar way that we introduce allergen exposure to try to precipitate a greater and greater allergic challenge that patients will eventually defend against.
Okay, thank you. Let's go for the second question because I don't see any questions sent by the audience. I will give some of the question that I would like to know if we know that in asthma and in rhinitis and in chronic rhinosinusitis, together with the type 2 inflammation, there is also this neurogenic inflammation, and sometimes it's very difficult to measure on that. It has been tried to investigate if type 2 inflammation has any role on the chronic cough. Because, for example, in chronic rhinosinusitis, cough is not considered one of the main symptoms to make the diagnosis, at least in adults, but is well considered in children. What is your opinion on that?
So I think this is a very important question that you raised, because apart from my cough clinic, I see a lot of patients with allergic asthma, moderate to severe, or even very severe uncontrolled asthma. But those patients, despite having very high levels of type 2 inflammation measured by sputum eosinophils, blood eosinophils, bronchoscopy specimens, most of these patients are not coughing hundreds or even thousands of times a day. So I think in some patients, in a subgroup of patients, something happens that maybe the eosinophilic inflammation or even mast cells may sensitize the nerves, and once they're sensitized, then the cough they live with for a long time. So I think there's a trigger that happens, that once that trigger occurs, the nerves then continue to be sensitized, and then they're very difficult to reverse. And as you can see, that the medications that we currently have, like inhaled steroids, bronchodilators, or anticholinergics, they are there to treat the smooth muscle and to treat the eosinophilic type 2 inflammation, but they're not there to directly target the nerves, which become hyper. And I think this is where new treatments are urgently needed to control that. We are actually just recently starting a trial on mepolizumab, a placebo-controlled, randomized controlled trial on the effect of mepolizumab or placebo on chronic cough in patients with asthma or eosinophilic bronchitis. So this will give us some information that if you kill the eosinophils from the blood and potentially even the airways, can you then get rid of the cough? That's never been done, and I'm hopeful that in the next year that will give us some very important answers.
It will be very, very interesting to know the results of this.
Yeah.
This trial.
So we're hopefully starting that study soon.
Very good. And a last question for Professor Altman. I would like you about the new treatments. Professor Satya has shown a variety of mechanisms. You also have shown a lot of mechanisms, central, peripheral, when peripheral, also TRP, purinergic receptors, PG receptors, and so on. Do you think that these new drugs, including those that antipurinergic or anti-TRP or whatever, could be enough or could be indicated in all patients with chronic cough, or we will need to split them in specific phenotypes and try to treat them only some groups, for example, with antipurinergic drugs or anti-TRP drugs or whatever? What is your opinion on these new drugs?
That is a great question. I mean, why not just suppress everyone's cough? And I think of the cough as that red light on the dashboard when you're driving your car. You have no idea what's going on under the hood. That alert is going off, and it could be that the bulb is broken or the wires are crossed or that something's really dangerous going on. So the danger of cough suppressive therapy without understanding the contributions and doing objective workup is that you can actually suppress those triggers and miss the tumor. miss the cancer, miss the aspiration, and miss the sinus infection or the bronchitis until it's too late, and then there's this overwhelming disease that succumbs the patient. So we have to be intelligent about it and understand when is there a role for cough suppressive therapy, and as long as the patient is under medical care and it's being followed up, then it can be done safely.